You take the injection. 48 hours later, you feel constant nausea. Your stomach feels tight, heavy. Heartburn keeps you awake at night. And you lie there thinking, did I just ruin this? Because this was not just another diet for you. This felt like your chance, your reset, your way out of the dieting cycle. Meanwhile, someone close to you has been on the same weight loss injection for weeks, sailing through it, no drama, no nausea, just a steady weight loss. So now you're wondering, why is their body coping while yours feels like it's pushing back? Is that bad luck? Is it the dose? Or is your body just not built for this? Here is what most people never get told. Side effects are not random. They follow biological patterns, they have mechanisms, and they occur for specific reasons. I am Dr. Almerie, a consultant weight loss surgeon, and I see this pattern every week in my clinic. In this video, we are stripping this back to biology. No hype, no scare tactics, no overpromising, just what the science actually shows. I will break down the real side effects, from the common to the serious. What's happening inside your body when they occur? Why they hit some people hard while barely touching others. By the end of this video, you won't just have a list. You will know what's expected, what's manageable, and what needs attention. You'll know when to stay calm and when to act. And more importantly, you will understand how your own medical history, your habits, your psychological background shape what you are more likely to experience. So instead of reacting blindly, you will know what to anticipate. And just to be clear here, this video is not a substitute for individual medical advice, but it will give you a clear framework to understand these medications, so you can have a more informed conversation with your doctor. Let's break it down. If you scroll through social media, your feed is full of dramatic stories. I developed this. No one talks about that. Here is the hidden damage they don't tell you about. And after hearing enough of these stories, it starts to get inside your head. You begin second guessing. Is the drug safe for me? Am I missing something? Should I even be on this? Now, before we go any further, there is something important to acknowledge. With any relatively new medication, especially as it is used by a larger population, our understanding evolves over time. Some side effects are well established. Some are still being studied to clarify the strength of the connection. And we have to accept that there may be things that we don't yet fully understand. This is not unique to GLP-1 medication. It is how medicine progresses. The key is not to react emotionally, but to follow the evidence, so you can make rational decisions that truly serve your health. And to do that, you need a clear organizing principle. When we look at the side effects in people using GLP medications, there are two biological forces at play which are causing them. The first is the drug signal itself, how GLP-1 activates receptors, how it influences different systems in our body, across our brain, the gut, and other organs. Now, the second mechanism is rapid weight loss. Here, the side effects are not unique to GLP-1 medications. We see them with any significant weight loss shift. The same patterns we have observed in weight loss surgery patients for decades. So if you separate these two categories, the biology of the drug itself and the biology of the rapid weight loss, you stop reacting to headlines and start understanding the mechanisms. And once you understand the mechanisms, trust me, the fear will lose its grip. Let's start with the most reported side effects, and one of the main reasons some people struggle early on, the gastrointestinal symptoms. This is what many people notice first: nausea, sometimes vomiting, a heavy bloated stomach, excessive burping, reflux, and changes in bowel habits, constipation for some, diarrhea for others. These effects were clearly documented in the original GLP-1 trials, the STEP 1 trial, the SURMOUNT 1 trial, and they are constantly observed in the studies that followed that. In most cases, these gastrointestinal symptoms were reported to be between mild to moderate. They tend to be more noticeable at the beginning and often settle as the body adapts to the doses of the medications. However, in a small proportion of patients, typically around 4 to 6%, as shown in major trials, the symptoms were significant enough to stop the medication. So they are common, usually manageable, but not trivial. So why do these symptoms develop? It comes back to what GLP-1 actually does. One of its key actions is slowing down the stomach emptying, so the food stays longer in the stomach. And that is part of how fullness lasts longer. But when food sits longer than your system is used to, the pressure will build in your stomach. The stomach stretches, you feel heavy, you feel unsettled. That increased gastric distension contributes to reflux disease. Slower movement can also increase bloating and belching, especially after larger meals or heavy fat meals. In more pronounced cases, the symptoms can resemble a medical condition we call gastroparesis. That is where stomach emptying is significantly delayed. GLP-1 also influences gut motility further down the tract. That shift in movement can alter your bowel habits, slowing things for some people, causing constipation, speeding things for others, causing diarrhea. These mechanisms explain the symptoms. Nothing random, nothing mysterious, it's just physiology responding to new signals. Now, what should you do about them? First, timing matters, really matters. These symptoms are usually most noticeable during the early phase of treatment. This is exactly why GLP medications are titrated. In early development of the drug trials, when higher doses were started immediately, gastrointestinal side effects were much more severe. Now, gradual dose escalation allows the body to adapt. It needs to adapt to the hormonal signals that change in them. So titration is not just a formality, it's a tolerance strategy. If symptoms appear during escalation, slowing the increase often helps. Now, diet is your first practical tool. Reduce the meal size, eat slowly, stop when you feel full, avoid large, fatty or very rich meals to start with, particularly in the early weeks. If your symptoms are mild, your GP may prescribe short-term support, anti-sickness medications, acid suppression medication. If needed, the GLP-1 dose can be adjusted, lowered or escalated more slowly, or sometimes even switched to another GLP-1 drug. And importantly, these medications adjustment should always be made in discussion with your doctor. Dose changes, supportive medications, or switching therapy should never be done in isolation. Now, in rare situations, if the symptoms are severe and persistent, the medication may need to be stopped and alternative therapies need to be considered. There are structured, evidence-based pathways for managing these symptoms. I have linked one of the key consensus papers in the description below for those who want to explore more details. Now, who might feel these symptoms more strongly? This is where your baseline matters. Not everyone starts with the same physiological reserve. If you already live with reflux, if you have irritable bowel syndrome, if your digestion has always been sensitive or unpredictable, then slowing down the gastric emptying and altering the gut signaling may feel amplified. GLP-1 does not create a completely new system, it interacts with the one you already have. If there is an underlying instability, the same signal can feel more intense. That doesn't mean the medication is unsafe, it means context matters. And this is where personalized discussion with your doctor becomes important. Pre-existing reflux may require earlier acid suppression. Irritable bowel syndrome may require slower titration. If you are prone to bloating, dietary adjustments become even more important. The goal here is not avoidance. The goal is anticipation, as understanding your baseline helps you predict your response and manage it proactively. And beyond the common gastrointestinal effects, there are rare signals that understandably attract more attention. These are far less frequent, but they carry emotional weight. So we need to look at them carefully and proportionately. Imagine this. You have been on the medication for a few weeks. Things have been manageable. Maybe some nausea, maybe some bloating. Then one evening, you developed severe abdominal pain. Not the usual discomfort, not mild indigestion, just feels different. The pain is deep, persistent, severe. And now you are wondering, Is this just another side effect, or do I need to go to the hospital? This is where understanding the framework matters. One of the rare but serious conditions discussed with GLP-1 medications is acute pancreatitis. That means inflammation of the pancreas. It is uncommon. Large clinical trials suggest the overall risk is low, and not all studies have shown a clear increase in risk. So what we call in medicine the direct causal link remains uncertain. But pancreatitis itself is serious, and that is why caution exists. Now, context matters. Some people already carry a higher background risk of pancreatitis. If you had pancreatitis before, if you have a very high triglyceride level in your blood, if you drink heavily, then your baseline risk is higher, whether with or without the GLP-1 medication. That is where individual discussion becomes important. Then becomes the pattern recognition. Mild discomfort is common with GLP-1, but pancreatitis pain feels different, persistent, severe. That's not something to ride out. It requires urgent medical assessment, not panic. Most people taking GLP-1 medications will never experience this complication, but knowing the difference between expected discomfort and a red flag pain gives you clarity, and clarity prevents both panic and delay. This is not about fear, it's about proportion and responding appropriately to your body. I have linked a detailed review paper in the description for those who want to read more about this specific topic. Another concern often mentioned is thyroid cancer. You will see this warning on the regulatory labels for GLP-1 medications. That warning comes from early animal studies. In rodents, high doses of GLP-1 were linked to tumors of thyroid C cells. But rodents are not human. In people, thyroid GLP-1 receptor expression is very different. As it stands in March 2026, large human observational studies have not shown a clear increase in thyroid cancer risk. However, caution remains important, particularly for specific groups of people. If you have a personal or family history of medullary thyroid cancer, or genetic conditions like MEN2, which are associated with higher risk of these cancer, then GLP-1 medications are generally avoided. That precaution is based on biology and regulatory guidance. For most people, current evidence does not show a meaningful increase in thyroid cancer risk, but long-term data is still evolving. That's not a hidden harm, it's a rodent signal that regulators chose to respect, while human evidence is continuing to accumulate to give us more information. For those who want to review the data, I have linked one of the major Scandinavian population studies in the description. Another emerging signal that has gained attention is a possible relationship between GLP-1 medications and optic neuropathy, often shortened to NAION. In simple terms, it's damage to the vision nerve. This can cause sudden loss of vision. It's uncommon, and this condition usually affects older patients who have vascular risk factors such as diabetes, high blood pressure, or other circulation problems. Over the past 2 years, some observational studies have suggested a possible association between GLP-1 medications and NAION. At this stage, there is nothing confirmed and there's no causal relationship established, but it's something being monitored and studied carefully. If you have already advanced diabetes or vascular disease, especially if it has already started to affect your eyes, your baseline risk is already higher. In that situation, careful discussion with your doctor is essential. For most people, the absolute risk remains low. Now we are going to talk about the side effects that fall into this second bucket, rapid weight loss biology. This is not about the GLP-1 drug itself, it's about what happens when your body shifts weight so quickly. These are patterns we have seen long before GLP medications ever existed. They are not new, but we need to talk about them because to variable degrees, they will affect you if you are taking GLP-1 medications. Now let me paint you a picture. You have a friend who struggled with obesity for years. You have not seen him in a while. Then one day you meet again. He has lost a significant amount of weight. You almost don't recognize him. The body is slimmer, his health looks better. But his face, looks different. Cheeks are flatter, lines are deeper, skin looks looser around the jaws, and for a moment, you think he looks 5 years older. That is what social media now calls Ozempic face. But here is what I can tell you from years of weight loss surgery practice. We have been seeing this pattern for decades in our weight loss surgery patients, long before GLP-1 medications existed. This is not a toxic drug effect. It's a visible anatomy of significant fat loss from your face. When someone loses a large amount of weight, particularly if it is done quickly, fat reduces everywhere, including from the face. Now, when facial fat volume drops, the skin loses structural support, and it cannot always retract at the same pace as the fat disappears. The mid-face flatten, the under-eye area appears hollow. The folds, they look more prominent because facial fat is a major contributor to the youthful appearance. Now, who is more vulnerable? We see it more prominently in people who lose weight rapidly, in those who lose a large amount. It tends to be more noticeable if you are over the age of 40 or 50 because natural age-related fat loss is already underway. If you already have a lower facial volume, the change feels amplified. And in smokers, because of skin elasticity being reduced, that laxity can appear more dramatic. So baseline reserve matters. So what can you do? Facial fat cannot be selectively protected. We cannot choose where the body burns fat first, but slowing the pace of weight loss can soften the visual transition. If the changes feels sudden or distressing, you can discuss with your doctor whether adjusting the dose to reduce the speed of weight reduction is something appropriate for you. And if someone is really concerned cosmetically, aesthetic options exist, but that becomes a personal decision. Now, here is the transformation. Once you understand that this is a structural fat loss, not hidden damage from the drug itself, you stop blaming the medication. You stop assuming something is wrong, and you start making informed decision about pace, expectation, and what matters most to you. Ozempic face is not a mystery, it's biology. And biology, once understood, is far less frightening. When you start GLP-1, you might be like many people. You step on the scale every morning, waiting for that number to show. You celebrate when it drops, half a kilo, another kilo, 3 kilos. For the first time in years, it feels like something is finally working. And naturally, your focus becomes the scale. How much have I lost? And that makes sense. But here is what many people do not realize. When people lose weight with GLP-1 medications, they don't just lose fat. A meaningful proportion of that weight comes from lean tissue, largely skeletal muscles. In major trials, including the STEP 1 trial and SURMOUNT 1 trial, body composition analysis showed that around 30 to 40% of the total weight lost came from lean mass. Now, this pattern is not unique to GLP-1. We see similar proportions after weight loss surgery. This is rapid weight loss biology, not a drug toxicity. But here is the real issue. You can lose weight while losing strength. You can watch the scale drop while your body is quietly giving up muscle. You can become lighter but weaker, smaller but less physically resilient. And that is the part that truly matters. When calories fall sharply, the body enters into an energy deficit status. If protein intake is insufficient and muscles are not being stimulated and preserved, the body will break down the lean muscle tissues to use it as a fuel. Now, appetite suppression makes this more likely. You are eating less, the portions are shrinking, and unless protein is prioritized deliberately, the total protein intake will fall. Let's put this in the right biological context. The rate of muscle loss during rapid weight loss with GLP-1 medication can be several times faster than normal age-related decline. After the age of 40, adults lose roughly about 0.8% of muscle mass every year. That is about 8% per decade But the amount of lean muscle mass lost during significant GLP-1 associated weight reduction can be equivalent to nearly 20 years of natural aging, compressed into few months. That doesn't mean the medication is aging you, it means rapid weight loss accelerates a process that normally unfolds slowly over decades. Some groups are particularly vulnerable. Older adults, those already experiencing age-related muscle loss, people with low baseline strength, people who are at risk of frailty or falls. For these people, additional muscle loss is not cosmetic, it's functional. Because muscle stabilizes joints, it maintains balance, it supports independence. And here is another layer. Muscle is metabolically active tissue. It burns calories at rest. It clears the glucose from the bloodstream and improves insulin sensitivity. Losing muscle lowers your baseline energy expenditure and makes long-term weight maintenance harder. If treatment is stopped, weight regain becomes much more likely. And when muscle has not been protected, that regain often returns primarily as fat. So less muscle, more fat, and a lower metabolic rate, that makes future weight regain much more likely. So what do? You treat muscle preservation as part of the treatment plan you discuss with your doctor, not as an afterthought. Protein intake must be intentional. Most adults undergoing weight loss should aim for roughly about 1 to 1.5 grams of protein per kilogram of their weight per day. In weight loss clinic, especially after surgery, we always emphasize one principle: protein first in your meal. Now, the second pillar is resistance training. Not just walking, not just cardio, but structured strength workout that is suitable for you. At least 2 sessions per week. Progressive loading, intentional muscle stimulus, because preserving your muscles will require both substrate, which is the protein, and stimulus. GLP-1 reduces appetite, but it does not protect muscle for you. That requires a strategy. And if you remember one thing from this section, let it be this. The goal is not just to lose weight. The goal is to lose fat while preserving strength, because the scale measures mass, but your body runs on function, and long-term health is built on function. It is 2 a.m. You wake up with a deep, gripping pain, high in your abdomen. It tightens, builds, comes in waves. You turn, you sit up, you pace, nothing makes it comfortable. 2, maybe 3 hours later, it fades. By morning, it's gone. So you tell yourself, maybe it was something I ate. If it was serious, it wouldn't have settled. Maybe it's nothing. But now, there is a quiet tension in the background. What was that? Why did it last so long? Is it going to happen again? And if you are on GLP-1 medication, losing weight, finally seeing progress after years of struggle, this hits differently, because the last thing you want is something derailing that progress. You have worked hard to get here. You have seen the scale move and have felt hope return. And now, one episode of pain is threatening the sense of control. You have seen the headlines, the warning videos, and suddenly, the medication that was helping you feels uncertain. Was that my gallbladder? Have I done something harmful? Should I stop? Now let's just slow this down and bring clarity back. Yes, GLP-1 medications are linked to a slightly increased risk of gallbladder disease, but context matters. When researchers analyzed multiple high-quality trials, they found the risk was modestly higher in people taking these medications. Now, what does that mean in real life? If 1,000 people take the medication for a year, about 3 additional people develop gallbladder disease. 3, not 0, but not dozens, not hundreds. 3 extra cases per 1,000 cases per year. That is the scale, and this is crucial. We have seen the same pattern for decades in people who lose weight rapidly, especially after bariatric surgery. This is not a hidden toxicity. It is a rapid weight loss biology. When weight drops quickly, the liver releases more cholesterol into the bile. At the same time, the GLP-1 medication slows down the gallbladder, so it reduces its squeezing motion. Now, the bile sits longer, becomes more concentrated, cholesterol can crystallize, and over time, those crystals can form stones. Now, a lot of gallstones cause no symptoms. Many people have them and never know. But when they do cause symptoms, it often looks exactly like that 2 a.m. episode. Severe pain in the upper abdomen, often in the right side, pain possibly spreading to the back or maybe to the right shoulder, pain in waves, often after fatty meals. They could last for several hours and then settle completely. If you experience these attacks of pain, that could be your gallbladder. Not something to panic about, but not something to ignore. Seek medical assessment. A simple ultrasound scan can usually clarify things. If stones are confirmed and are symptomatic, they might require surgery. So here is the balanced takeaway. Yes, the risk of forming gallstones is slightly higher, but in real terms, we are talking about roughly 3 additional cases per 1,000 of people on the GLP-1 medication per year. Understanding that scale restores perspective. It separates fear from fact. It separates headlines from biology. And most importantly, it restores your sense of control. So if your body ever sends these signals to you again, you won't spiral at 2 a.m., you will recognize the pattern, you will seek assessment early, and you will make decision from clarity, not fear. If there is one message I want you to leave with, it's this. We are not identical biologically. We don't have the same physiological reserve. We don't have the same medical background. We certainly don't have the same genetic wiring and gut-brain signaling strength. That means we will not respond to GLP-1 medications in the same way. Some people will barely feel side effects. Others will feel the physiological shift very strongly. And sometimes one specific side effect will affect one person far more than another. Not because they did something wrong, not because the drug is good or bad, but because their biology is different. And as I explained in my previous video, obesity is not a simple GLP-1 shortage. It's not like we are replacing a missing hormone and fixing one broken pathway. GLP-1 medications act in multiple systems and organs. And when you influence that many systems at once, the response will never be perfectly predictable. That variation is not a reflection of willpower or effort. It's not a personal failure. It is systems biology. So the goal is not to blame yourself, because misunderstanding this leads to guilt, fear, and poor decisions. It's not to panic, it is to understand. It is to anticipate how your body might respond, to prepare for it, to recognize patterns early. And if something does happen, you don't quit blindly. You work with your doctor, you adjust, you individualize, because GLP-1 treatment is not a one-size-fits-all journey. It's a partnership between your biology and informed medical guidance. And whatever your body response has been, it makes sense in the context of your biology. The more you understand that, the safer, calmer, and more confident that journey becomes. Now, in the next video, we are going to tackle an uncomfortable question in almost everyone's mind. Why does weight so often return after stopping GLP-1? And do you need to stay on them for life? Does the original biology reassert itself? Is weight regain inevitable? Or are there things you can do now while you are on the treatment that protects you later? You will find the link for that video up here. I am Dr. Almerie. If this way of thinking helps you make sense of these treatment, please subscribe so you are first to know when the next video is out. And if you know someone who is on these medication or thinking about them, share this with them, because understanding this properly can completely change how you approach it. Now, if you are already taking a GLP-1 medication, I would genuinely like to hear your experience. How has your journey been so far? Have you noticed troublesome side effects? Any unexpected changes? How did you deal with them? Please share it below, because your experience might help someone else make sense of theirs. Thanks for being part of this conversation. I will see you in the next video.